My name is Dr. Tyler Tolbert,
And I'm Dr. Soren Paape,
and you're listening to the Fix Podcast.
your source for all things implant dentistry.
I get my first 4.
Yeah.
So my assistant's handing me pilot, then she's handing me 2.0, then she's handing me 2.3, then 2.6, and then it depends like what the bone density is of where I'm stopping there. But effectively, every single time I'm just doing all 4 osteotomies super quick throughout. When I'm ready to go, she's like, "You ready to place implants?" I'm like, "Yep." So then she has my, and man, almost every single case I'm doing, I'm placing 3/8 by 13, 3/8 by 11/5s. So 3/8 by 13s on my 2 posterior, 3/8 by 11/5s on my 2 anterior. That's my go-to. Everybody has their own go-to, but that's mine. And I very rarely sway from that. The only times I sway from that is if I can't get torque with the 3/8, then sometimes I'll jump up to a 4/5. And the reason I like placing 3/8s is because usually I can get stability jumping up that 0.7 millimeters. It's like enough for me to regain some of that torque. If I get like halfway and I can tell, oh no, this isn't going to work, I don't put the implant all the way in and increase the osteotomy size. I will like play work, take it out, and then go to a 5.0 for my implant. So
Yeah.
those 4 implants are in.
This is such a. No, I was just gonna say that's such a like rookie mistake. Is you're not really feeling a ton of resistance with the drill, but you still just place the one you're planning on and pray. If you don't feel that resistance, then maybe you go as far as starting to place the implant. If that torque isn't really starting to jump up, you should really go ahead and kick up to another size, like not just a half step, but a whole step. For instance, if you were placing a 4 and you didn't get a lot of stability and then you go to a 4.5, you've only gone up half a step, and the implant itself is actually bigger than its corresponding drill. So you've already widened the osteotomy, so that next implant isn't going to be grabbing any more bone than the first one was. So you're going to have to skip it. But what Soren is saying is go ahead and do that skip, get a feel for that haptic, get a feel for if the implant's not going to work, go ahead and place that next size up. That gap from 3/8 to 4.5 is a little bit better than just a half step, and it actually can work. So that I totally agree. I use 3/8 95% of the time.
Yeah. But yeah, so all the implants are in then. And I'm telling you, like, at this point, like, we're usually probably like 25, 30 minutes in, and we've got all the implants placed. Next step, we jump to pterygoid. So when I'm placing my last implant, my assistant's sitting there with my long pilot drill, and she grabs the long pilot, places it on. I do my pterygoids with the drill protocol. I have placed them with the osteotome protocol. I've taught a lot of doctors with the osteotome protocol. I know how to do both. I prefer the drill protocol personally. So long pilot, do my right pterygoid, do my left, same thing, switches them, right, left, switches them, right, left. And then we're placing. Pterygoids are in. At this point, it's 30, 35 minutes into the case. Sometimes even less than that, right? If my cases are taking 45 minutes, like sometimes a little bit less than that. Next, my assistant's literally sitting there with a 17-degree multi-unit. I almost always place a 17-degree multi-unit on my pterygoids. So she hands me that. I check the angulation of both. Then I grab, she also will have the 1-2, my 1-2 driver on my contra angle handpiece set at a 50-20. So 50 RPMs, 20 Newton centimeters. Once I get the 17s where I want them, grab that handpiece, lock them in. They're both torqued, ready to go. Then I grab, she hands me my 2 30-degree multi-units. I place those. I'm super anal at this point about my angulation. I do not want to be switching my multi-units when I'm going to finals. So I will take an extra, whatever it is, 5 minutes to get my angles all perfect. I want them all to come out of the central fossa if it's like a posterior tooth, or right behind the incisal ledge if it's an anterior tooth. So I'll spend a little bit of time to make sure everything's parallel, everything looks like it's where I want it to be. So 30s go on, and then I torque them down both sides with that contra angle handpiece, and then my straights go in. I rarely use 17s on my straights. I usually angle my osteotomies forward quite a bit, and I want them right behind that incisal edge. That just comes with practice. Sometimes when you start, you'll probably place some, and you're like, oh, I got to put a 17 on just to get the angle. That's fine. Not a big deal, but once you have done hundreds of arches, you'll know exactly where those implants should be. So all the multi-units are on. All the multi-units are torqued. Then we take all the multi-unit holders. You know what they're called? The metal pieces on top of the multi-units.
The rods. I just call them the carrying rods or whatever.
the carriers. But yes,
Yeah.
take all those off. Then my micron mapper photogrammetry scan bodies are going on. My assistant's over here setting up the micron mapper for me while this one is helping me. Oh, she's handing off. I'm like handing her my driver. She's loading the next one while I'm putting the other one on. So it's just like my assistants are constantly moving while I'm moving, right? I'm not sitting there grabbing each micron mapper scan body. My assistant's handing me a driver with that micron mapper scan body on. And that's the difference, right? Like that there's so many doctors out there, me included, who when you start, you're taking the scan body, placing it, grabbing the next one, trying to get it to engage in the 1-2 screw, placing that one. No, they're handing me I'm moving. For my pterygoids, I always will use a contra angle, just my implant motor. I'm moving with a 1-2 driver on it, and I do it at 50, I think 10 Newton centimeters, and I'll hold the micron handpiece not back there with the patient bodies. If you try to go quick on your multi-unit part, and one of your multi-units is like crossing over the other one, good luck getting that scan in 30 seconds, right? You're going to be sitting there trying to get that scan. You can't get it. Then you got to take a scan body off and do 2 scans, have your lab merge them together. Doing these little steps ahead of time and doing them correctly will save you time down the line. So once you get the micro mapper, take all the micro mapper scan bodies off. I use Nobel white healing caps. Put the Nobel white healing caps on. I then use a 5mm tissue punch that goes on my implant motor. You can get these anywhere, but I use a 5mm. Grab that. I tissue punch all of my implants to make sure that my flap's going to lay properly. After that, hand that to my assistant. They're handing me a suture, and I'm doing 2 simple interrupted sutures in between all of the scan bodies. So at this point, I have all my records done. I shouldn't say all because you still need to take the impression at the end, but I have my photogrammetry done. I have my scan bodies on. Everything's sutured. We're at the 30, sometimes 45-minute mark, hour, but rarely do my cases take in that time. Like, it's all handing me stuff. I get everything sutured on the top. We're not skipping a beat. I like to sit my patient up a little bit when I'm doing the lower. Patient sits up a little bit on the lower, and then the bottom is the exact same way. My assistant immediately is handing me a large straight, elevating all the teeth. Then I grab a 151, getting the molars out. I do use a cow horn on the lower molars if there's a lot of furcal bone, but then it's ash for all the anteriors. Then laying my flap, same thing. About at that first molar mark, I'm doing my releases. I do my and motion across the lingual bone. It's one sliding motion, one on the other. I do my lingual first, then I reflect my releasing incision up, and then peel that keratinized tissue forward, and then release it all down. Now in the lower anterior, you're going to get a lot more periosteum attached there. At this point, I will look at my patient, and a lot of times, like, people, especially in the beginning, their lower alveolar will look like this. It'll be canted. I like to close my patient and look at the lower upper, and that helps a lot for me visualizing, okay, I know my upper was straight because I was looking straight down on it. If I close them, I can see where the discrepancy is on the lower, and that helps me out a lot on my lower alveoloplasty. And then, my assistant's got my pilot drill on my handpiece. Punch those front 4 in. If I'm doing straights in the back too, if they have enough bone, I do those as well. And then I go through the whole sequence just like I did on the upper. Suture that all up. I'm about an hour 20 to an hour and 30 minutes in when I get the lower sutured. Assistant hands me the upper denture. Make sure it fits okay. Make sure the midline looks good and everything. Do my impression on the upper while that's setting. If I have a good stop, grab the lower, impression on the lower, and before I do the impression on the lower, I close them, make sure that their bite looks good. Do the impression on the lower, grab the into the bite reg, take the whole thing out, hand it to my assistant, and I'm out of the op. My assistant, our design.
You prefer to use a bite reg and then scan outside the mouth as opposed to doing it in the mouth?
Yes, I do. The reason why is because the assistant then has to scan upper, lower, and then put them both in, and maybe she doesn't know like where my bite was, or I have to come back in the op.
Yeah.
Takes me 30 seconds to do a bite, and then everything's out of the mouth. My CRNA can wake my patient up while my assistant is doing the scans. That's why I prefer it.
Got it.
So that was a lot in a short period of time, but I just wanted you guys to visualize like how you know what are the steps, what's going on. That's what's going on. I do it the same way every single time. My cases all look the same. And that's not a bad thing. That's a good thing. Like I want my cases all to look the same. I want someone to look at one and look at another and be like, think it's the same case essentially. My setups always look the same. We do everything the same every single time. And that's why I hear a lot of doctors, knock on wood, who are like, oh, I'm having this medical complication or all these issues. We don't get those very often because our surgeries are efficient.
They're in and out.
My assistants know what they're doing. My CRNA knows what they're doing. If the patient's only asleep for an hour and a half, it's hard for them to lose a ton of blood in that period of time, or to be under so long where they're getting like crazy fluctuations in their blood pressure. A lot of times you get those issues because the patient isn't numb anymore. They're starting to feel the surgery, blood pressure's going up, and that's when emergencies happen. If you get your team locked in, it's super efficient. A lot of those complications that you see just won't occur. Also, like we said before, slow is smooth and smooth is fast. Making sure throughout the procedure you're doing everything correctly. You're not like sitting there flying through your multi-units and all of a sudden all your implants look like they're like this, right? And not like straight. Then it's going to take you that much longer. Then all of a sudden you're going to get to seating your prosthetic and you've got a 40-degree divergence from one implant to another, and it won't seat. And then I got to reprint the whole prosthetic. Like do it right. Do it slow at first. Make sure that you do everything correctly, and then once you're doing these things correctly, you're doing them the same way. You'll start to see that it gets quicker and quicker, and you won't fall over your feet as you're going through these cases and having to go back and fix problems that happened in the past. Ask me how I know. I've made every mistake in the book. I've done it all, and I am not saying that I learned this stuff without issues. I've probably made every mistake that you as listening have made times 10. But now we're to a point where I can do these in my sleep. It's just my assistant knows what they're doing. Both of them do. I'm just hanging out along for the ride. We're listening to good music in there. It's become something that previously, prior to a surgery, you'd have a little bit of anxiety going into it. Now it's something that's fun. And we've gotten there through a lot of practice, a lot of research, a lot of trying different techniques. And you'll find your flow with your team, what works well for you.
I think something that I just really hope that people take away from this, and there's some little nuances in what you talked about that I want to expound on a little bit, but just in broad strokes, what I want people to understand is that the least valuable thing you can take away from this is that Soren is fast. That there's no point in knowing that or thinking that at all. What's important is Soren has systems, and these systems have been developed over time through very incremental change and just being absolutely obsessive about every single step and making it as efficient as possible, and a commitment to that. And it's not just him, it's his whole team and how they know and understand that surgery. And I'm sure that you just said you could do this in your sleep. I'm sure your team mentally could. Like they could walk through the entire surgery, everything you do, every instrument you use. And if your team couldn't do that, either done a lot of surgeries with you, or you're shooting from the hip in these things and they don't exactly understand what you do and they're just waiting on you to tell them what to do. And in that little bit over the entire course of a surgery can add up to additional hours. Like it's not just seconds. You can't think of every one little thing and just think, oh, that's only going to save a few seconds. All of it saves many seconds, and every single step there is time saving in everything that's done. And over time, that's how you're cutting out an hour, 2 hours, 100%. Right? Like I would say, I can't really say for sure what's average. I've seen a lot of first timers. I've seen a lot of people who have done like a handful of arches. I would say in general, like a double is like, it can be a whole morning for like your average person.
I would say 4 to 5 hours, 2 to 3 hours per arch is probably average.
Pretty average. Yeah.
Yep. And
Yeah.
if that's where you're at, there's nothing wrong with that at all. I know people who've been in surgery for 8 hours on these cases consistently. Like my CRNA works. There's a lot of offices in Denver that do this, and my CRNA will come and be like, "Man, this case, like, I go there once a week, and it's like 8 hours for a double."
Yeah.
And all I can think
Yeah.
about is, man, all the risks that patient's in being asleep for freaking 8 hours. That's just not.
Yeah.
That's not like good patient compliance is my opinion on that. It just means that you didn't take the time with your team to get ready for these cases, and your team doesn't know what they're doing probably if they're in surgery for freaking 8 hours. But I would say on average, like 2.5 hours per arch is pretty like normal.
Pretty normal.
Yeah.
Yeah. Yeah. And like you said, that is okay. But what I'll tell you too is like when you first start doing these and they're taking you 2.5 hours to do an arch, it's really exhausting mentally and physically. I remember my first double the case turned out okay, but I was in shambles. I mean, I was like torn apart, and it's not as fun. Like when you do like really long surgeries and you're having these sorts of complications with patients that are moving around so much that it's 5 minutes between each stitch because they're moving and they're ornery and they just want to go home and they're trying to talk and no one understands what they're saying. It's miserable for everybody. So like these things, surgery will get better over time and more enjoyable, and you reach this sort of zone of nirvana where things just go smoothly and everyone knows the drill and every surgery feels relatively the same. And if you're really fast, all those sorts of complications and patient management issues, they start to go away because they're directly proportional to how long you're taking. Also, in your post-ops, you won't be so scared to see your patients because they're not going to be covered in bruises, they're not going to be miserable, they're not going to be swollen up like a balloon. I haven't seen anybody in my chair that was swollen up like a balloon, and I can't even remember the last one that I saw, and that was almost ordinary for like my first few cases because they were long and there was a lot more inflammation, and I was tearing periosteum in my flaps. That causes a ton of inflammation and pain. If you do a full thickness mucoperiosteal flap, you're not going to run into that nearly as often. So all these things, they really do improve outcomes. This is not about being productive for the sake of money. Yes, you can make more money and you can do more efficient surgeries. You can even do multiple surgeries in the same day. You can do doubles. You can even do the triple double that some people have been doing. Like you can do more than 1 or 2 arches a day, but also you're going to have better outcomes, and the quality of your cases also gets better by following these protocols because it's not about rushing through. It's not about beating a time. It's about doing it efficiently and doing quality surgery. And the steps that are necessary to do that also happen to make you a little bit faster too. So making that commitment and really getting anal about it will, over time, just like these little changes in your surgery will cut off a bunch of time, these little changes that you make throughout the course of your career and all these surgeries that are now going faster and smoother and with less complication will make your life better. It will make your practice stronger. It will make your patients happier. So it really is important. It's more than just speed. It's really just the overall quality of what you're doing in full arch. But yeah, just to zone in on a few things that you were talking about, you explained everything beautifully and I really appreciate it. One thing is Alveo. So there are a few things that I have picked up in how I do the Alveo, but also evaluate the Alveo. I find that my perceptual ability is fairly poor. Like I can look at an arch and think it's perfect, and then I'll turn from the side and I'm like, oh, I totally missed that. So I had to get a little bit more routine about how I actually evaluate my Alveo and how I do it in the first place. So on the upper, I'm a big fan of doing half and half. So you're never going to, I think it's pretty rare to just go all the way around the arch, just like all the way back to front to back, like in one pass. I usually like to do things in approximately 2 passes, right? So in the very front, I'm looking at the interior. I'm determining what my reduction is going to look like. Standard is 15, but of course, everything goes back to the high smile line. You want to look at that Duchenne smile, see where that lip is, add 2 millimeters at least, if not 3, and then that is going to be your measurement from the incisal ledge. Super, super important point. I don't want to just gloss that over. I start on, let's say, the left side. I don't even know what side I actually do first, but I start and just to if I'm doing the left side, I'm biasing a little bit on the number 9 side of the midline, and I will take that coarse cylindrical Meisinger burr. That's a black stripe burr. Super, super useful. I wouldn't use it in every single spot, but it is very aggressive. It eats bone. It's incredible. I go down and do a depth cut. I get to where I want to go. And then I'm fixating my eye, just how you talked about the establishing the tragus line. Thank you. I'm looking down that allotragus line, and I'm fixating my gaze from where I first dip into the bone to get to where it needs to be, and I am setting a mental plane, and I'm not going to move my eyes. I'm going to look right down this plane, and I'm just going to cut all the way back from that spot. Keep that same depth and pull it all the way back and keep it flat. I don't want to see, I'm fixing myself on this plane, and I better not see any bone that comes up above that plane. If I'm looking at it dead on and I see some bone up there, I need to reduce that. And I'm going to take it all the way back to the hemular notch. I'm going all the way back. And you should be doing that even if you don't place pterygoids. Do it every single time. Make that routine, and then you won't have to learn it later. You're going to do this every time. It makes your cases look cleaner, gives plenty of space for additional teeth. Do that routinely. Once you have a really nice half of the mouth, now you can do the other side, and now it's easier because you're just matching. It is much easier to match one side to the other when one side is already done perfectly. If you're just reducing everything at one time and just trying to figure out the high spots, it's like playing whack-a-mole. You're just hitting all the high spots, and then you're hoping that everything ends up flat, and then your eyes are getting tired, and then you look at your post-op and you're like, that was not flat at all. Yeah. So try to be systematic about that, especially with the upper. That's very useful.
Can
and
I
I'm always
interrupt you
doing
quick?
this. Yeah, please.
Two things. Tyler mentioned go all the way back past that, like to the back of the tuberosity. Nothing says a novice full arch surgeon than like you have your alveolo is like to that first molar, and then it's just a freaking huge divot there.
It's just artificial combinations.
Yes, I see it all the
It's dips
time,
down
and
in
I'm
the
like,
back.
man, just
Mhm.
go all the way back, finish your work,
Finish the job.
make it look clean.
Yeah.
Your pano's gonna look crappy if you don't do that.
Yeah.
Really important.
Yep.
There was one other thing, but continue on. I forgot it.
Yep. So that's my course cut. I try to do that in one pass. That's usually my goal, just one pass all the way back, and then I'll swap. I like personally to swap to a finer grit just for polishing a little bit. Like I like to have really nice round edges. I just like how the flap adapts to like really round corners. You get less dehiscence and things like that. So I'll swap. I really like in certain burr blocks. I think the affordable burr block has this one. The TFAP SPG collab has this one as well. It's like a tapered burr with a blue stripe. You can go, and it's very quick. You just go right down the line angles of the bone after you've made this very flat shelf, and you just round those off. I just like to do that. It looks cleaner. You can get any like residual periosteum or granulation tissue out that way as well. And then I just repeat the process on the other side. And then for the lower, another thing that I learned from Matt Krieger is using the external oblique ridge to set how low you should be going in the posterior. So you're going all the way back, and you're flapping well enough so you can actually visualize the external oblique ridge. So I'm starting there, and let's say I'm using my left hand. I dip it down. It's at the upper, but in reverse. I start in the back. I dip it down the external oblique ridge, and then I actually just rotate my hand forward, and I try and keep it fixated, and I lock my wrist and rotate it all the way to the midline. So to try and do that in one pass. And my proximity to the mental nerve as I pass over that should be about 5 to 7 millimeters. I should be getting pretty close to it by following that external oblique ridge. As I come to the anterior, if the centrals are still there, I should see those sockets disappear. Now, granted, if that had extruded out or super erupted, that marker goes away. But it's really nice to have a tripod of reference points. Your distance from the crest of the ridge to the mental, as well as getting the central sockets eliminated, and just try to triangulate all that and make it really nice and flat. So starting from the external oblique ridge, carrying it forward in one pass, and then I can switch hands and do it with my right hand, do the exact same thing. Or if you like, this is about the only time I'm not at 12 o'clock, I'll go in front of the patient, and then you can go front to back that way as well and match the other side. It's just so much easier to make the sides match than do it all at one time. And generally, I used to worry a lot about under reducing the lower. When I'm looking at those three markers using the external oblique ridge and then getting rid of the central sockets, I have not had an issue of under reducing the lower. JB Dental Lab might tell you. So that's just how I like to do the Alveo.
Yeah, for sure.
And in terms of evaluating it, before you move on to the next thing, look from a bunch of different angles. Look from the side, maybe on the upper. You can even get a Fox plane if you want to and sit it up on the bone. Some people do that, and you can see from the side, did you parallel the tragus line?
I like that a lot. I think that's a great thing to do. I remember what I was cool. One thing I'd recommend doing that I've seen a lot of doctors do the other route is over reduction. You can do over reduction. And something I like to do is when I place those teeth and mark my line at 15, I'll actually mark it at 13. And that gives me like...
You got to know your biases.
Right. So like 13, and then I make sure that I get rid of the whole line. But a lot of times, cut down to there, and then all of a sudden you're looking at it from different angles. You're like, oh, I need to reduce a little bit there. I need to reduce a little. And then all of a sudden you like are placing, you can be at a point where you're placing your anterior implants, and you're like, oh man, I'm like 2 millimeters in the nose. And you don't want that, right? Like you fix cases from doctors who have over reduced, and it's not fun.
That's a good point.
So just, slow as smooth as fast, whatever the quote is. Just take your time on every single step. Don't just blow through the alveoloplasty, over reduce, fix it. You're fixing it because then you're going to have issues in the future.
I'm really glad you say that because I just know my biases. I'm a light-handed person. I tend to under-reduce. And so I had to mentally get a little bit more aggressive with my Alveo to get the speed down. But there are definitely people that put way too much weight on it and just tear it up. In that case, you use a finer grit burr, slow the hell down, and make sure you're
Just
being
know,
careful with
like
marks.
I think it's just a great thing you said. Know your biases, and then take the steps accordingly. We've given you like I said, we've been on all ends of the spectrum, so we're trying to give you tips for different biases. If you over reduce, maybe make your line a little bit short. If you under reduce, make sure you add that line in and actually cut to the line. If you under reduce, maybe every single time you cut till the front incisors are gone.
Yeah.
Know what issues you have and try to take things accordingly. Did you have anything else that you wanted to go over?
I would say incision design. So you definitely talked about that in terms of vertical releases up the maxillary buttress on the upper, going all the way back. The other thing I want to ask you about is, do you do straight line incision? So the concept of this is, as you're going, provided you have adequate keratinized tissue, and ultimately that's the decider in a lot of this. But instead of going circumferentially around the teeth and going like papillae, like through the papillae and actually tracing the papillae, do you just establish a straight line, a common denominator across all these papillae to give you that straight line incision? Okay,
almost every time. On the upper, it depends on the case, right? But like from tuberosity until I get to where those teeth are, and then I do one across the buccal, cutting off all those papillae, and then lingual, and then I go back with a rongeur and just get all those papillae so it's nice and straight, and everything will come so it's nice and straight. But yeah, that's how I do it.
I got another one I have two more, but I'm going to go to the one that I think is a little bit more important first because I'll probably forget the other one. Multi-unit timing and placement. So I think it's really important to be very routine about this. Your multi-unit placement at first I remember when I first started, I dreaded this part because timing the implant and getting it to come out in the right place, fiddling around with the multi-unit, profiling bone and stuff like that, it would slow me down so much. As far as the profiling bone and things, I think that has a lot to do with how you do your alveo, but also has a lot to do with how deep you place your implants and the profile of the multi-unit itself. Not all systems were designed specifically for full arch, even though they may have multi-units. If they're really bulky, you're going to be profiling a lot more often. That's just an additional step and something you have to screw around with. Most of the full arch specific systems out there, like Neodent, I think Megagen, and they have much slimmer multi-units. Like you hold these up next to each other, and there's obese ones and there's very sexy ones. But once you're placing your multi-unit, timing the implant on the upper generally, and please, Soren, your timing is wonderful. So if I'm wrong on any of these, let me know. I got cases tomorrow. So when you're timing your implants, always looking at the dot that indicates the flat side of the hex. So when I'm placing my pterygoids and my tilteds, I get that dot to point towards my midline. So I'm just visualizing where that midline is at. Sometimes I'll actually turn my head and look at the implant that I'm timing directly, and I get a dot to stare back at me from the midline. And then as I get to the interior, those midlines just go straight back at me. They're not pointed at the midline necessarily. And if you can get that to where you time it the same way every time, what happens is your multi-units, you're not even having to fiddle around to find the hex. It actually just drops right in. Like you can literally hold the multi-unit in the sort of angle correction you want it to have. You're going to be correcting 30 degrees this way, and it's going to be correcting this way, and you're going to have in that orientation, it'll drop right into the implant because you know that you've timed it the same way every single time. The more you do that, the faster you'll get, and eventually you won't be fiddling around with multi-unit so much. You'll know that it's timed correctly, that it's going to come out where you want it to. So being very routine in how you time every single one of those implants is really important.
Yeah, for sure. Take an implant and just spend the $60 or whatever it is, however, not 60, probably $100 for your implant, and just take it out of the package and look where your multi-unit is coming out of that implant.
Yeah.
So you can get an idea of, I need to angle my implant this way so my multi-unit comes up here. This is where
I totally agree with that. Can we also talk about, and this is something you helped me a lot with, I used to rely a lot on guides and multi-unit placement guides. I would always have that for the upper. I use them for the lower. They weren't that great just because they don't always seat that well. But on the upper, I would need to put that guide in to check where my multi-unit placement is. Recently, I have not done it at all. I don't think I've done it in 6 months. How do you perfect your multi-unit timing? How are you always having such good prosthetic exit? What are your reference points? How are you doing that so predictably without having to compare a bunch of stuff and seat a guide and all that?
Yeah, absolutely. For me, I don't use a guide at all because like I said, I'm marking 15 millimeters. I know where my reduction is, and for multi-units, this is how I do it. my upper multi-units all should be relatively parallel. They should all be flaring out buccally
Equally flared.
just a little bit. I like to look at where I'm gonna probably finagle this terminology, but if you look at where your maxilla is flaring, your maxilla flares as it comes up where the teeth are. My multi-units almost match the flare of the
Follow
maxilla.
that flare.
That's what I'm looking
that makes
at.
sense.
And so everything is flared. My anterior ones are flared a little bit forward, and my number 4 and 13 are flared a little bit buccally, and then my posterior ones, my pterygoids, are flared like a little bit buccally and a little bit forward. And the reason I like that, some people like to place 30s. I like to place 17s because my assistants who are taking my prosthetics on and off are able to find that easier when there's a little bit of a buccal flare. What's nice about the Micron Mapper, and not everybody has this luxury though, is that it actually tells you exactly what your divergence is.
Yeah, it's the best.
I think the max divergence you can have is 40 degrees. My personal max is 30.
Don't go to 40.
Is 35. I like 35.
Yeah.
If it goes above 35, I'm changing my multi-unit because I don't want down to where there's a zirconia and all of a sudden be in an issue where I can't seat that zirconia, because the zirconia is much more rigid than your printed temp or your analog temp or whatever you're using.
Yeah.
So that's my upper. On the lower, now I just know looking at it, but very similar. Less of a flare on the lower, just a slight flare. Everything parallel. I like to close them on the lower when they are in there, and I want them to hit like just inside of where those uppers are, or just where the upper teeth would be. So I close them usually, and that's how I do my lower multi-unit placements.
Yeah.
But when you start,
Fantastic.
don't do that. When you start, use a guide. Like use a guide.
Yeah.
I don't know,
Yeah,
until
you
like your first 100 arches, and then
Yeah.
you'll know, okay, I know exactly where this is coming out of where the teeth are.
Yeah, and I think one of your most invaluable advices to me when I was trying to get rid of doing the guides, because I was annoyed with having to print them for every case, and they didn't always seat perfectly because sometimes those designs can be off. No shade of JB. Is putting the teeth back in the socket. So one thing that I had issues with early on was getting a proper prosthetic exit in the anterior, which made for thick prostheses. One of the most common issues that you'll have early on, more than likely, is thickness. Not always in the posterior. You may have it, but it might not actually bother your patients that much. What will bother them is having a thick anterior hard palate area, because your exits came out way too palatal there. It's hard for them to clean. It affects their speech. It feels really thick. It's much harder for them to get used to, and it's a harder thing to fix. Like, you're going to have to change a multi-unit. So one thing that helped me out was try to get those upper anterior teeth out whole, of course, and put them back into the socket. So when I go into that sort of that palatal island between the central and lateral teeth, I will actually put my drill right there. I'll stick the tooth there, and I'll just go ahead and angle the drill such that it would come out the cingulum. Now, this is with the caveat that I'm preserving the class relationship. If I'm changing that at all, obviously I have to make some changes there. Like if the upper teeth need to come back, then I need to be coming out a little bit more palatal than I would. But assuming that we're preserving the incisal edge position, I'm able to measure with the natural tooth exactly where that cingulum is. And the prosthetic exits have been absolutely money since I started doing that, as well as that slight buccal flare is really good. The timing, looking for that buccal flare and using the existing teeth has completely eliminated guides for me, and I'm not going back. I think the only indication that I would see for it is maybe like a really atrophic case that was a edentulous that I don't really have a lot of reference for, or one where I'm doing extreme class correction. I did a really fun one a couple months ago where it was just like a complete class 3, upper was entirely inside the lower, and in that case we did have some guides, so I could check out that relationship, and ended up being on the money, and the patient's class 1 now. Is so cool.
Nice. That's awesome.
Those are amazing cases, but that's the culmination of like really nailing down being able to do all these things in a class 1 relationship. And once you get really comfortable with that, you're not needing to use guides, you'll feel a lot more comfortable with those types of cases.
Perfect.
Yeah.
Well, I think we've hit a lot of efficiency tips.
For sure.
If you guys have any questions about our surgeries, if you have any questions about little things we've talked about, if you want us to expand on them, reach out. Again, my Instagram is Dr. Soren Paape. Tyler's is Dr. Tyler Tolbert. More than happy to reply to any of those. You can also reach out to us at the Fix Podcast. That's the Instagram tag handle. We'd love to answer questions on there as well. I do want to get say one more quick one for those of you who are doing analog conversions. Take your you always need to figure out like where those implants are coming out right prior to putting temp cylinders on, because you need to drill all those holes.
Yeah.
So take a bite reg of the intaglio under your denture prior to suturing. That way you can hand that denture off to your tech, and he can be drilling out the access holes while you're. Don't wait till after you're suturing and then sit there. Tech is drilling those holes out. Do it before the suture. Make sure that you don't get any bite reg under the flap. Hand it off to him. Let him do that, and then that way, right when your suturing is done, you can start putting those temp cylinders on, and it'll be like right about when your tech is passing it off to you. Before you do the pickup on the upper, get them numb on the bottom. That way, after you do the pickup, you hand it to the tech. The patient's already numb. You start on the bottom. Those are probably my two big ones for analog. But yeah.
And the upper conversion doesn't have to be completely done to do the lower pickup. Don't be waiting on the lab to finish their upper conversion before you do that. You can just screw it in wherever they're at in that process. I'm sure they've at least done the backfill. You can just screw it in, do the lower pickup, and then you hand it off, and they'll finish both of them at the same time. You don't want to be waiting on a lab process. Also, another caveat, I was always a huge advocate for using lab putty instead of bite reg, because it doesn't have a liquid phase. So you can either use lab putty, or you can use like a silly putty like material. I've actually used silly putty before. Don't use the kind with glitter in it. What's really nice is that you can mold it into the denture, and then you can do the seat, and if it didn't come out right, you don't have to load up another tip and do another bite ridge. You just smooth it over and do it again. It's rigid enough to where they can drill through it without a problem. It's reusable. You could even reuse it on the lower as well. It was just a small speed tip. There's a putty block is available through like major suppliers, but like I said, you can also just use some like silly putty from Amazon. I'm past that world. It's not my world anymore, but it was a pretty good one that I was pretty passionate about. Yeah. Anyway. And if you have a sinus exposure or something like that, it's not going to run up into the sinus. We have seen bite reg get into someone's sinus before.
That's a good point.
But yeah, no, I think this was an amazing episode. I really hope that there's some implementable bite-sized tips here. There's probably like 200 tips that you just gave people and absolutely dropped gold on them.
I hope
if you guys are out there, and if you guys have anything that you explained a little bit better, you need some more pictographic information or demonstration, we can definitely try to provide that. You can also email us at thefixpodcast@gmail.com. I did recently make a short where I included all the forms that we've made for you guys to send us some feedback and some suggestions and things. We're actually going to put that in the Instagram bio as well. So if you have any questions for us to answer on the show, suggestions for topics, guests, you can go that route. If you have a case you want to show off, or you have a case you want to help with, you can do that. Or if you're looking for sponsorship on the show, we have forms for all of those things. So please engage with that. We'll be looking for it, and we can't wait to start mentioning some of you guys on the show. We're just having so much fun with it, and we want you to too as well. So
Thanks so much for listening, guys. We'll see you next time on the Fix Podcast.
you got it.